Assalamu alaikum. Firstly, I'm very appreciate about the previous paper which is done by Dr. Bashir. Yani, you are a big hero. This is challenging cases, rare cases, and should be to be published in international magazines because we didn't, they will not find it in other developed countries. So I'm very proud of you and of the others. And sorry for not attending from this conference. Firstly, congratulations for all Somali association doctors for their first event, and particularly Mr. Dr. Abdel Shakur and Mr. Ashraf and their crew, and also congratulations for the new executive committee for holding next 2 years. Our presentation, patellofemoral joint instability, is the common disabling condition affecting the knee joint, challenging treatment problems with high frequency rate. Let us start by the first slides showing this picture was taken from one of the textbooks. There is a multiple procedures have been described in the literature in the management of the recurrent patellar dislocations or patellofemoral joint instability. When you have a multiple choice or a long menu in the restaurant, this is making you a bit confusing. Which way is up? The usual scenarios of the patellofemoral joint instability started by traumatic patellar dislocation. It's one of the common causes of traumatic hemoarthrosis. When you find hemoarthrosis, you have to think more than twice for ACL injury before patellar dislocation. It is commonly occurred in the younger peoples, active, and they have long-term impact of patellar dislocation about considerable pain, chronic instability, and eventually with osteoarthritis. When we do have high index of suspicions, because of the most cases, the majority of cases reduce spontaneously. So when you find this is the field, it is unwise to get the X-ray, to send the patient for X-rays. You have to reduce or to do something before sending the patient to the X-ray. We know that the patella, we have a multiple anatomical structure that directed the patella in each side. But the main function of the patella is act as a fulcrum or as a polymechanism to increase or to improve the efficiency of the extensor mechanism. We learned in the university that the main stabilizer, static stabilizer, is the medial retinaculum, lateral retinaculars, but later by Laprat, after 2007, there are specific and quantified ligaments like MPFAL and other like MPTL and MPL. So this is the main stabilizer, soft tissue stabilizer for the stability of the patella. We know in the near extension of the knee, the patella, it lies outside of the trochlear groove. Whenever the knee flexes, the patella starts to engage into the trochlear groove. So the more flexion we have, the more engagement of the patella inside the trochlear groove. Let's to go, why that case? There are multiple causes of patellofemoral joint instability. The first one, if we have no ligament, the patella will float without any direction. So here, the patellofemoral ligament is the main structure of soft tissue, main stabilizer. The second cause is the high-riding bacteria, high-riding patella, like patella alta. So it takes long time to be engaged inside the trochlear groove. The third cause, when you got abnormality of the trochlear groove, so we never find bone to hold this patella inside the groove. The other three causes, The torsion, this is secondary to other deformities of the lower limbs, like torsional deformity, valgus knees, or other deformity makes lateralized patella or tibial tuberosity to the lateral side. The most common cause of the patellofemoral joint instability, the non-contact injury, more than direct contact injury. We know that for every traumatic patellar dislocation, should MPFL to be injured every time. We have no general agreement for initial management of the patellofemoral joint instability. We have to address what are the risk factors making this chronic instability after traumatic patellofemoral dislocations. The first one is the patella alta, the high riding patella, and the most surgeons prefer using Caton-Deschamps index rather than insult-Salvati ratio by the articular surface of the patella and the line between the lower poles and the upper pole of the tibia. The second, the huge factors, is the trochlear dysplasia. So we don't know more specific what type of the trochlear dysplasia, more than it is present or not present. So by the lateral X-ray, we can know the trochlear dysplasia, what running from the normal to the flat to the convex type. The other factors is the lateralized force factor, which is estimated by Q angle, and this is which quantified by what is called tibial tubercle trochlear groove distance, TTG distance, and nowadays we prefer to use tibial tuberosity with the PCL distance, and should be less than 20 millimeter. So this is in the X-ray, in the CT scan superimposed to look the difference between the axial lines from each structure. We think about the other factors also affecting patellofemoral joint instability. We have learned that about 70% they have osteochondral injuries. And also I encourage you to keep track of this study. It's talking about risk stratifications for the risk factor, addressing risk factor of the patellofemoral instability. The classic dogma that all traumatic patellar dislocation treated by non-operative management. Okay. Unfortunately, about 70% they have recurrence, and there is one study that showed that 68% is not. And this is one of the examples of risk satisfactions. There is no role for acute MPFL repair. So MPFL reconstructions, it reduces the recurrence rate up to 0 degrees. There is some clear acute surgical indications. There is a schematic treatment for the treatment of the patellofemoral joint instability. So this is how to assess for the patients and the limbs and soft tissues. This is the MRI finding of the axial for the MPFL. And this is one of the cases which is done in Sudan. Unfortunately, I couldn't grab cases here in Somalia. This is the history. This is showing the imaging. This is the Caton-Deschamps. This is the tibial tuberosity and tibial tubercle distance. This is the trochlear groove. This is showing dislocations. This is the finding, arthroscopic finding of the chondromalacia of the patella. This is how showing the trochlear, how shallow. This is the patella translation test, which I prepared from other side by me. This showing how this is translated more than other side. This is by the image showing the scrotal line or spots in the femur. This is a key point for success of the operation of the reconstruction of the ligament. This is the finding of the reconstructed or new MPFL. This is the minimal invasive minimal incisions for the same patients. This is 3 weeks after operations. Conclusion is still non-operative for all the patients of the traumatic patellar dislocation. We have to consider surgery in high-risk individuals MPFL reconstruction is the mainstay of the management. Always we have to address other major risk factors. Thank you very much.